Global Vascular Meeting today. And before we start, I would like to wish, on behalf of all of us, I'd like to wish our gurus and our gurus of gurus a very happy Guru Purnima. So, like Dr. Robin said, we have a few arterial cases to discuss today. But before that, I would like to hand over the stage to Dr. Dean for his presentation first.
So this was a guy I got asked to dialysis catheter because he had severe heart failure, and they had a hard time pulling fluid off during his hemodialysis. So he was getting edema in his legs. So they go, "Oh, we can't do hemodialysis because his heart isn't tolerating it. Can you do peritoneal dialysis?" So this is his right arm. I examined his fistula, and this thing is flowing like crazy. Right? So it's got a rip-roaring thrill. It's got a rip-roaring bruit. And I go, boy, there's tons of flow going through this thing. Next slide. So I looked through his chart, and there was an echocardiogram from a couple months earlier. He's got left-sided heart. He's got left ventricular hypertrophy. He's got right ventricular hypertrophy. He's got pulmonary hypertension, dilated atriums. I mean, this fistula has been working for 12 years, and he's never had problems with it. So the way I saw it was the fistula was causing his heart failure. And if you did peritoneal dialysis, you were doing nothing for his heart. Next slide. That's not the next one. Go again. Go again. Go again. So preoperatively, I asked for them to get flows in the fistula and in the brachial artery. And if you look volume flow, they're saying, oh, maybe 3 liters, 4 liters, whatever. But the bottom line, it's not accurate. Getting flows with ultrasound is not necessarily accurate, but it confirmed that there was tons of flow going through here. So normal cardiac output's 5 liters. I mean, this guy's got an additional 2, 3, 4 liters going in his fistula. So I said, we need to ban this thing, decrease the amount of flow. So go back up to a prior slide, go up, up. So intra-op, I made an incision and I put a flow probe that circles around the fistula, and I measured out to 2 liters of flow. So this isn't necessarily perfectly accurate, but just the same, it confirms the fact, again, there's tons of flow going through this thing. Next slide. So I banded this, and it's not the greatest of pictures, but this vein, his fistula, right beyond his anastomosis, and he was about 8 millimeters in diameter, and it was flowing like crazy. So I reduced it down. I put a probe into it, call them Hager dilators. I don't know, they're metal. I put a Hager dilator in there, cut some of the vein away, oversewed it with proline to narrow it down to 5 millimeters, and then I measured flow again. I also put 2 silk ties around it to help keep it from ballooning back up again. Next slide. And after I banded it and reduced the flow, here it was down to about 500 cc's a minute. So the next day he had hemodialysis, and they were able to pull off 1.5 liters of fluid, and then he had dialysis again yesterday, and I don't know what they were able to do yesterday, but it already seemed to have made a difference. He was able to get full runs of dialysis, so we'll see. So the lesson there is you know, some of these fistulas, some of these people with heart failure, it can be due to their fistulas. We've talked about it, but we don't see it very often. So it was just something to keep in mind. And if they start doing more peritoneal dialysis in Nepal, which is probably years away, You got to keep an eye on their fistula. The other people we see that can go into heart failure with rip roaring fistulas that have been working a long time are those that get kidney transplants. So you got to watch out for those people too. Some of those people can go into heart failure. And that's it. That's my case.
Yes. So thank you, Dr. Dean. Thank you for a very interesting case. So we have done only few banding into the hill, but I want to ask, like, we don't have the flow probe. So in our case, can we use the ultrasound, intraoperative ultrasound, to determine the flow, things like that, or?
So when you say, yeah, I mean, if you learn how to do, right, you got to know how to do the flow using ultrasound. You could use that. And it's not a great science. In other words, it's not very 100% accurate, but you want to know, have you made a difference?
Yeah.
Can you detect a difference? You can probably tell by just feeling it. And then the other is listening. And then if you have a way to quantify it, that's good. If you don't, well, you do your best.
Yeah.
The other argument you could say for this guy is I should have just ligated it. Now the problem there is this guy is not real smart and he lives alone. And I think the chance of him being successful doing peritoneal dialysis, I think, is very, very low. So that's the other reason I wanted to save the fistula. Otherwise, you could make the argument that we should have just ligated it completely. But I think that'd have been a
but
problem
Dean,
because
but
I
Dean,
don't think
that
he'd have been able to do PD. What's that, Florian?
but that wouldn't have come to my mind. I would always have gone for the same as you did, like go for a try and see, reduce the flow. And I also use Hager dilators. So you just see, and that's maybe to also answer your question, because we don't have flow probes either. We had them in the university, but the problem is actually you need one which is perfectly fitting. So if you have an 8 mm vein, you need actually a flow probe that exactly fits. If it's too narrow, if it's too tight, then the flow is not accurate again. So, but it's definitely good for like having it before and then afterwards and see if there's a reduction. But if I have if the main problem is this high flow and it's something estimated around 2 to 3 to 4 liters, and the vein is like 8 millimeters to 10 millimeters, then you use the Hager dilator and you, exactly as Dean says, you just reduce it to that volume or to that width actually, and then I mean there's a reduction afterwards. You have to see clinically what's happening. Is it okay or not? I mean that's basically it.
So when I band it, yeah, then I cut a good portion of the wall away also. You can't just, make a little cut and put the dilator in and then sew it. I actually cut some of the wall away.
Yeah, that's right. I was wondering, Dean, so this patient, I mean, we sometimes see that over time they develop these high volume flow fistulas, but in that case, it seemed to really extremely high flow. So this guy didn't have any shortness of breath or any clinical signs of the heart failure or the right heart overload.
He did for over a year. He had for good
Oh,
length
okay.
of time, but nobody recognized it. I mean, the cardiologist never thought of it. The nephrologist never thought of it, that the fistula could be causing his problem. Nobody thought of it. Yeah,
Which
that's
again,
right. So that's
I
not
mean,
so smart.
yeah, that's exactly. I mean, this is really interesting. I mean, he's seen by a doctor 3 times a week
Yeah,
by
no.
a specialist. A nephrologist is a specialist.
And a cardiologist. He's been followed by a cardiologist. They have echoes that show right ventricular hypertrophy, pulmonary hypertension,
So
high flow. I mean,
and that's interesting. I mean, there's one wing of the plane is breaking, so and the plane can't fly any longer. What's the reason? Yeah.
So it's right. So I just thought I'd present it,
Yeah. I think actually the lesson to learn from this is, as you said, I would always go for a try and reduce the flow, because otherwise you don't have an access, and you don't know if he develops, if, for example, if you create a new axis on the other arm, for example, then he might create the same problem. So over the years, so I would always go for a try, and if it's clinically okay afterwards, if you see a success, then it's good, and if not, I mean, you can still just close it down. You can just ligate it. That's not the problem, I think. Yeah, but interesting case. I've seen several patients who had such high flows, but I've never seen anyone really having these clinical problems. May it be due to the fact that those patients who mostly are high age don't move as much as young people do. They don't walk around very much, and so they maybe don't have the feeling that there's something like shortness of breath or other problems. Yeah, interesting.
So Dr. Dean,
Well, and
in this case,
it reinforces the idea that you should feel and listen to these fistulas. I mean, all the time. So you got to learn what normal is so you can recognize abnormal. I say this all the time. And in this case, the abnormal was there's too much flow. This is too good, working too good. And it's got to click in your head that you can't just say, oh, this is good flow. Oh, it's too much. So you got to recognize, I teach it over and over. You got to recognize what normal is so you can recognize abnormal.
Yes.
All right, next.
Dr. Dean, one quick question, like in this case, for banding, can we use some graft to wrap around the vein and tighten it? Like
Right. So I used to do that. I used to take, like a Dacron patch like we use for carotid patching. I used to wrap that around. And then what happened is one of them, the flow was a little low. Well, then of course, interventional radiology went in there and blew up the balloon and burst the whole crazy thing. So that was a mess. So what I do now, if you look at the picture, I just put a silk tie around it to help keep it from increasing. So, and then you'd say, well, if they could balloon that too. Yeah, but I think the idea that they could pop a stitch, fits in my head, or that the stitch might be able to loosen if they blow it up. So I don't put the Dacron around it anymore. I just put a couple extra ties around it, silk ties. Once I've reduced it, I put the tie on, then I measure the flow, make sure I didn't tighten it too much, with the idea that then it won't increase. And
So I usually use a patch to reinforce the result, because otherwise it might become widen again. I mean, not if you have the silk tie around it, that's right, but yeah, I do it.
some people have written about putting the tie only, but
Yeah.
What they do is they do it in IR, they put a balloon down there, put the balloon up, and just take a stitch percutaneously, go around it, tie it. Yeah, I'm not into that.
No.
Yeah, thank you very much. So Mandeep, kindly continue.
Next presentation is by Shwecha.
Okay. So do share the screen.
Hi, hello everyone. Namaste, Dr. Dean, Dr. Flurry. Happy Teachers' Day. I'm on call today, so this phone is ringing a lot. I'm sorry for that. So, this is a case of just a minute. So this is a case of Mrs. Rai, who's a 52 years lady who presented to the emergency department with complaints of pain and swelling of the right leg for 4 days. She also added that she had fluid-filled blisters over the anterior aspect of right leg for 3 days. There was an alleged history of fall injury from nearly 1 meter height. sustaining impact over the right knee. For the above complaints, the patient was taken to a nearby healthcare center where X-ray was done, which showed anterior knee dislocation, and relocation was done in the healthcare center. However, when symptoms didn't subside and the leg pain persisted, she presented to the emergency department 3 days later. She does not have any chronic illnesses. However, she has history of multiple trauma to the same knee over the past years. Next slide. On examination in the emergency department, there was edematous right leg, and as can be seen in the picture, there was blackish blue discoloration of the right leg with multiple bullous lesions over the anterior aspect, largest measuring 3 into 4 centimeter. On examination, both limbs were cold. However, the right leg was cooler than the left, and there was diffuse tenderness on the right leg. I palpated the pulses, and femoral pulse was palpable bilaterally. Popliteal pulse was palpable on the left side. However, right side popliteal pulse could not be palpated as the patient had extreme pain. The anterior tibial and posterior tibial artery pulsation was not present in the right leg. However, it was palpable on the left side. Next slide. We performed a quick bedside ultrasonography, and we found out that there was no flow in the anterior tibial artery. However, there was biphasic flow in the posterior tibial artery. This was the ultrasonography report given by the radiologist. However, when I did a bedside ultrasound, I found out that there was no flow in the popliteal artery as well, and there was no feature suggestive of deep vein thrombosis. Next slide. We performed a CT angiography, and as can be seen in the picture, there was a thrombosed segment in the right popliteal artery. However, the distal and the proximal segments of the popliteal artery, that is the common femoral artery and the anterior and posterior tibial artery, had flow. Next slide. So this is the CT angiography video of the patient. Next slide. So in view of popliteal artery thrombosis, the patient was immediately shifted to the emergency department, and the orthopedicians were informed. They performed the external fixation of the knee of the leg to stabilize the knee so that it does not harm our artery any further after the anastomosis. The patient was placed in prone position. Next slide. So as can be seen in the picture, similarly, the accept incision was given on the popliteal fossa to avoid contracture. The short saphenous vein was identified, and the sural nerve was displaced laterally to facilitate further dissection, and popliteal artery was identified. The slide ahead before. So we found out that there was a thrombosed segment in the popliteal artery. Dissection of the artery was done, and as can be seen in the picture, there's the thrombus noted in the popliteal artery. Fogarty catheter was inserted and the thrombectomy was done. The fresh margins were anastomosed by end-to-end anastomosis. Later, the orthopedician also performed prophylactic fasciotomy to prevent delayed compartment syndrome. Next slide. So this is the intraoperative picture. So in the picture, we can see it's blurred, yet we can see the dissected end, and there's a big thrombus in the area in the proximal segment of the popliteal artery. Next slide. So this was the pre and post-operative, post-relocation X-ray of the patient. So this was in the healthcare center, and this was after the relocation was done. Next slide. So post-operatively, the patient had flow in the anterior tibial and posterior tibial artery. The patient complains of pain in the right limb. However, there are no fever spike. The wound site showcase is minimum. And anterior and posterior tibial artery are palpable with a saturation of 95% noted in the right foot with normal waveform pattern. Can you play the video?
Sorry, just a second.
So today I also performed a handle Doppler examination and we noted flow in the anterior and posterior tibial artery. Since the incision site are multiple with including the fasciotomy incision site, the patient complains of pain at the incision site. However, there is no wound site infection in the patient around the popliteal fossa. So this is what the initial part. Please play the video. Yes, thank you.
So good. Now, my question, if I saw that right, you transected the popliteal artery. Is that right?
Yes,
And then you did end to end, or did you do a bypass?
end-to-end anastomosis.
What would you have done, Florian?
I would have done a longitudinal incision because the reason for the thrombus supposedly is a blunt trauma due to the dislocation. So the interior wall is usually damaged and rolls in. This is why there's a local thrombus. I wouldn't have done a thrombectomy because there seemed to be good flow until this little obliterated part. So I would have done a longitudinal incision, would have fixed the inner layers that were damaged or removed them and then put a patch in. That is what I would have done. But if it works out the way you did it, it's absolutely fine. The problem is that if you see intraoperatively, once you have done the transaction, that there's a problem with the length of the ends of the popliteal artery, and that the damage of the walls may be longer than like a centimeter or so, then you're not able to mobilize the arterial ends and do an end-to-end anastomosis. But then you have to interpose some graft or something like that. The result is pretty good, actually. So you did the right thing, but beforehand you never know how long that segment is, you know.
Yes,
So, right. I think the main point that one of the main points Florian's trying to make is the dislocation caused damage to the artery. And you don't know where in the artery that is. I mean, it's in that segment somewhere. So if you open it longitudinal, you're going to find the damaged portion. You're going to be able to fix what caused the problem. And that longitudinal incision might be 1, 2, 3, 4 centimeters. Okay, I mean, probably shorter. And then you patch it. I would have passed Fogarty's also, yet Florian's right. I mean, you didn't see any clots. You wouldn't have to, but I probably would just the same. You just wouldn't be aggressive with it. So I would have approached it as Florian said. Your result is perfect. You did the operation, which is great. But I think you got to say to yourself, well, what if this thing would have clotted the next day? You'd say, well, why did it clot? It's because you may not have fixed what caused it to clot in the first place.
But absolutely 100% with you, Dean. But at the same time, I really want to congratulate you in a way, because I remember one case of a 40-year-old lady where you did in the same situation a Fogarty maneuver from the inguinal region, and you damaged the whole superficial femoral artery. So that was a disaster in my eyes. And now the approach, the idea behind it was different, was much better actually. So you located the problem, and so you located the problem, the underlying problem, which was the dislocation. You did the ultrasound, the clinical investigation, the CT scan, and did the operation. So overall, it is done very well. And I think this has to be really stressed in this situation. That's good. It's really good. So this is improving or improvement of your skills compared to what I saw half a year ago.
The other thing, I mean, where the blisters were, that was over the anterior compartment. So you're exactly right. You needed to do fasciotomy for sure.
Also, yeah.
So
Yeah.
you can't just go there, oh, the artery there, I'm done. You got to do the fasciotomy. And if they don't need it, no problem. You end up just sewing it shut a couple days later. If they needed it, well, then you're glad you did it. So just because you fixed the artery, you did the right thing to proceed with the fasciotomy.
And I also like the investigation next day, Swetcher, like you use the Doppler probe. I would have put it in a 45 degrees angle to align it with the arteries. That gives you better results. But otherwise, it's the right thing you did. The sound tells you that there's good flow in it. And that's enough. So you don't need do a big ultrasound or anything with this patient who is in pain. And so you do this Doppler investigation and you have a very good, this whipping sound. And that tells you that both arteries are patent and that there's good flow in it. So yeah, overall, it's just good. I'm happy to hear that actually.
Thank you. Dr. Satish
Made
was
a
in the
good
operating room, so Satish can comment some. So Satish, are you hearing us?
Yeah, Dr. Flores said that it was his thought that was in my mind when I saw the case. And the interesting thing about this case was the ultrasound done by radiologists. They said that it was a triphasic flow in the popliteal artery. But as you guys always taught us that anterior dislocation